Dr. Duke Machen, CEO and founder of Duke Spine Institute. And we are here today to perform a Duke laser disc repair surgery on a patient who has two herniated discs in her lower back, L3-4, L4-5. And she's having left leg symptoms. So we're going to be going in on the left side, the side that the leg hurts, the side of the symptomatic leg. We call it symptomatic when patients are having problems. We call them symptoms. The type of symptoms that people get when they have a herniated disc that's irritating or pushing on a nerve is either pain down the leg called sciatica, numbness in the feet or leg, tingling like pins and needles or a small electric current. We call those paresthesias. And then the last symptom is weakness that they can get. Now, people with herniated discs don't always have leg symptoms, and they certainly don't always have all the symptoms. There are 4 types of symptoms that the nerve root compression or irritation will cause. As I mentioned, pain down the leg, numbness in the leg or foot, tingling, like buzzing feeling, paresthesias, and weakness, okay? And not every patient has all of those leg symptoms. Some only have 1 or 2 or even a combination. Now, watch your hands. Don't ever keep your hands up there. Let go. Once you get up that high, you let go. Have we cooled the room?
Yeah.
How come just now?
I know, I do it when as soon as I get here, at 5:45, I put it at 48, and I believe it's because too many people here in the machine. Yeah.
I'm not sure about that. But you're saying, when do you, so you have to lower the temperature when you get here?
Usually is
It's supposed to be automatically, yeah, it's supposed to be automatically lowered with a schedule.
yes.
So is that not happening?
So it's happening later. So what I do is just I cool down as soon as I get here. In that case, at this point,
All right,
it's be cool.
that's fine.
Yeah.
Okie dokie, we are ready to get started.
And in your hands, you're gonna have this, right? Be careful with the.
Okay, can you hear me?
All right.
All right, this is Dr. Duke Machen. We're going to be putting you to sleep in a few minutes, but I need you awake for the very beginning. Once I get everything set and we're ready to get started with the actual surgery, we're going to put you to sleep. All right, are you comfortable where you are? All right. So I'm going to be talking to you sometimes, and I'll let you know. I'm going to be talking to the anesthesiologist sometimes, and I'm going to be talking to my team sometimes. So you're going to hear a lot of talking. And the reason you're going to hear a lot of talking is because that's what typically happens in an operating room. People talk until you get into the surgery, and then things get a little quieter. But in the beginning, there's things that I need. For example, I need your blood pressure to be lower.
We started 160 over 90.
I'm sorry?
We started 160 over 90. We have metoprolol, labetalol.
I don't care. I've done over 1,200 D surgeries. We need it down. Okay? Systolic should be about 110, 100, 100 max, 110 max. All right, I'm going to give you, do you know why her blood pressure may be volatile? She takes Xanax.
Yeah, she's
So,
not taking any,
Yeah.
anything for blood.
Yeah, she's not taking any now. All right, this is my hand on your back, okay? And I'm going to give you some numbing medicine. So you're not going to be happy about it, but you'll feel a little stick and a burn. All right? Just lay still. If you feel pain, say ouch, and I'll give you some more numbing medicine. But you'll feel just a little stick and burn, and that's just the numbing medicine going in. So don't get upset about it.
That's too much stop. I can't take that. Oh my God. That hurt.
All right. I've stopped. Is that better? All right. So the good news is, as the CEO and founder of Duke Spine Institute, I get to talk to anybody here the way I want to talk to them. And when I tell somebody something and I have to tell them 2 or 3 or 4 times the same thing, I start to get agitated, just like anybody else would. And so it's going to come out in the way I talk to people. But some people think I'm mean, but that's okay, because I really don't care what people think, to be honest with you. What I care about is my patients and how they think, and how we get rid of their pain, because that's why they're here. They're not here for a show. Doctor, it's always the same thing. This is a woman with high anxiety on Xanax. You have to give her something when I'm coming in and injecting her. Everybody's going to be uncomfortable with the injection. So that's up to you to give them something so they're not reacting that way. We've talked about this 2 or 3 times already.
Yes, sir. Sandra?
I don't want to have to keep stopping what I'm doing so you can treat the patient. It should already be done before I get here.
I'm working on that though.
Let me have the numbing medicine again.
Sandra? A lot of pressure.
What do you got in here? Xylocaine? Are you better now? All right. Just let me know if you're having discomfort, okay? Otherwise, lay still.
Pressure they cannot take away, okay? A lot of pressure. No pain, pressure.
Ah, that's not pain. Ah.
All right, I'm sorry.
I can put her down until we do that.
You know, I don't know what to tell you except that when Santiago was here for a whole year, we never had that. So he was doing something, and he's your friend, and you should be talking to him and finding out what he did.
Where's the fentanyl?
Let's go lateral, please. All right, so why do we broadcast our surgeries live? We broadcast them live so the world can watch and see what really happens during the procedure. We're not editing or covering things up. We want everyone to see what it's really like. And, you know, sometimes we have situations that we have to deal with, and you get to deal with them with us. So we call it reality TV. Shot. The purpose of these videos is for education. Educate the public. Shot. There's a lot of misinformation or misunderstandings about spine surgery and outcomes of spine surgery and how it's done. This gives the public an opportunity to tune in and watch a live spine surgery as it's being done. We broadcast pretty much all of our spine surgeries. Shot? Because we want everyone to see exactly what it is we're doing when we do these surgeries. So they can ask questions during the surgery. AP? All right, so today we're going to be performing the Duke laser disc repair. What is that procedure? When people have herniated discs that are causing symptoms like back pain or neck pain, arm symptoms such as numbness, tingling, weakness, or pain down the arm, those symptoms are due to a disc problem, a problem with the disc. Back to a lateral. She's doing good from my standpoint. Are you okay? What'd she say?
Absolutely.
Good.
Sandra? Don't move, okay?
You're doing great. Just lay still. It's Dr. Duke Machen here. All right. This is a $10,000 scope. Don't let it hit anything metal. Don't let it get damaged. It's your job to watch it. All right. So the herniated disc is causing this patient's symptoms for 2 reasons. Number 1, the tear in the disc in the back, called the annular tear, and not just any annular tear, but the annular tear has to be in the back of the disc to be painful. It has to be in the back because there's a special innervation of the back of the disc. Can we get that end plate lined up better, please? You not see the end plate is not perfect. So it needs about a degree or two of wag. But Jordan, that's something you should be doing on your own. That's worse. Let's go the other direction. See if we can get the blood pressure down a little bit more. All right. I think that's better. I think that's better. Thank you. All right. So if you count the discs from the sacrum up, the first disc is L5S1, the next one is L45, and the next one, which we're actually at right now, is L34. We're on the left side, and we're at L34. We're doing L34, L45, so we're doing this disc and the next one down. It may seem odd that I'm mentioning that, but one of the most common problems in spine surgery is operating at the wrong disc, which I've never done in my entire career of 22 years and thousands of patients, because I'm very careful and I constantly go back and make sure I'm doing the right disc before you actually get started on doing your disc surgery. All right, so the annular tear in the back of the disc is a source of back pain, or if it's in the neck, neck pain. Are you comfortable? All right, we're almost halfway done. How's that? Shot? I'm in the foramen with the needle, and I've just made contact with the herniation. I can actually feel it. I've done this enough times. Shot? Perfect. Where do you feel that? I'm sorry? Yeah, right in your back. Good job, Sam. You know, there was once a hobbit named Sam. Did you know that? No? You don't know The Lord of the Rings?
No, I never watched that.
Well, you need to go watch it, okay? That's a requirement to work here. You didn't know that? Have you watched Star Wars?
No, I never saw.
Louise, how do we hire this guy? Seriously. No Star Wars, no Lord of the Rings. I had one of my employees the other day, he said, Dr. Dude, give me some advice on dating women. And I said, what advice do you want? He says, I want to date, but I don't know how. I said, all right, your first assignment is go and watch 10 James Bond movies. You got a kick out of that. All right, so getting back to the real reason we're here. Are you comfortable? All right, so Jordan, you know where we're going next, right? So we talked about a herniated disc that has a tear in the back. All herniated discs have a tear in the annulus fibrosus. If the tear is on the side or the front of the disc, it doesn't do anything. Doesn't cause any problems for patients. If the tear is in the back of the disc, then it causes pain. And back pain is one of the things that Duke laser disc repair cures. It cures back pain, it cures neck pain if we're talking about a cervical disc herniation. The other symptom that people get from herniated disc is either a pinched or irritated nerve. And I say pinched or irritated because many people's symptoms down their arm or leg from the nerve root don't come from the nerve root actually being pinched. It comes from the nerve root being irritated. Shot? So how does a nerve root get irritated? Well, it gets irritated. Are you comfortable? Medicine. It gets irritated by the tear in the back of the disc where there's inflammation going on. That's the source of the back pain, remember. That inflammation spills out to behind the disc where there's a nerve root. Shot? Take it. Actually, take this. I think we've given enough. Take it. And that inflammation gets onto the covering of the nerve root, which is called the dura, D-U-R-A. Hey, lay still. Shot. Shot. Are you comfortable? What? Are you having pain? Skosh? Skoshi? It's Japanese. Did you know that? Skoshi is in Japanese, it means a little bit. All right, AP. So these disc herniation cause two types of symptoms, back pain and leg symptoms. They cause back pain by inflammation inside the annular tear, which we're going to fix with the laser by cleaning up the annular tear. And they cause leg symptoms by irritating the nerve root right behind the disc or compressing the nerve root. But I will tell you, it's irritation 99% of the time. Compression doesn't really cause leg symptoms except weakness and numbness and paresthesias. But the pain down the leg comes from nerve root inflammation. Sean, where do you feel that? Lateral. Where do you feel that? That's referred pain. So she feels, I'm touching her disc and she feels it in her crotch area. So we call that referred pain. It means the pain is being referred to one area of the body from another area. Very common problem. All right. Well, where do you feel that? Where?
The left side pelvic area.
Is that where you typically get pain?
Yes.
Amazing, isn't it? I mean, you know how many people have pelvic pain from a herniated disc? Very few. Very few. But that's the way you were wired. That's the way God made you. And because of that, your pain pattern is a little different than the next person. So everybody's pain pattern is a little different. The mistake people make is they go to the textbook and they look and say, oh, the L45 disc causes pain down the leg. But it would never cause pelvic pain. But yes, it does. Well, listen, it's almost over, but there is one thing I have to do before we put you to sleep. It's called a discogram. Have you ever heard of it? I'm sorry. But if you get angry with anybody, get angry with the anesthesiologist. All right? How bad is that on a scale of 1 to 10? 10? All right. 10 out of 10 at L45. I'm sorry. Yes, okay, I've stopped. All right, so what is that, folks? I just injected a little bit of dye. Just relax, you're fine. You see this syringe right here? Yes, ma'am, it should be easing up. I just injected about, what, a cc, maybe 2 cc's of liquid. And that went into the disc. If you look at the x-ray, you can see a black line in the middle of the disc. That's actually showing you where the tear is. It's coming out the back where the needle is. That tear in the back of the disc is the cause of her back pain. Did you have back pain? 10 out of 10 back pain. It's her typical pain she gets every day. So that tells me that that disc right there is causing her typical back pain. Okay? We call that concordant pain. We do the discogram for two reasons. Number one, to confirm the source of pain. Number two, because I need that blue dye in there so I can see where the tear is, so I can fix the tear. Remember, the tear causes the back pain. The tear also causes inflammation.
10 seconds, you're going to be sleeping.
Where do you feel that? Is that your typical pain? How bad was it on a scale of 1 to 10? 10. All right, 10 out of 10. All right, I got some good news for you. We found the 2 discs that are causing your back pain. When you wake up, they'll be fixed and it won't cause pain for you anymore the rest of your life. Isn't that great news? Lower the table a little bit, please. Just about half an inch. I'm so sorry, but count from 1 to 100 out loud, and if you get to 100, I don't have to pay our anesthesiologist today. You'll save me some money, so count fast. Good, good. Look at her counting fast. Don't you love it? That's right, nice and fast. All righty. Yes, surgeons do joke around in the operating room from time to time. You're doing great. Keep counting. Can you count in Japanese? I'm just kidding. I'm just kidding. All right, so for those of you watching, before the Duke laser disc repair procedure that you're about to witness, it's done endoscopically through a 7mm incision, before I developed this surgery, this patient, the only way to get rid of her pain would be to cut her open from here to here, move all the muscles over, expose the spine, then remove the bone in the back, clean out the 2 discs with sharp instruments, curettes, put in 2 new spacers made out of plastic, and then pins and rods, screws and rods. And it's called the transforaminal lumbar interbody fusion. And it works great, by the way. If I were doing that today on her, we'd get rid of her pain, no problem. But look at this surgery. We're doing the entire thing through a little cut. We're not doing any fusion, no metal, no screws, no rods, no cages. It's just a natural repair of the tear in the disc. And I can eliminate her back pain. I can eliminate her leg symptoms. If you ask my patients after surgery, how much of their pain do we get rid of? I'm talking about months after surgery, not just today. They'll tell you 95% on average. Half of the patients say 100%. How did the table go down even lower? It should have gone just a little bit, but it looks like it went even lower. Are you able to drop your fluoro to the table, to the floor? Or you're down? All right. Give me that's it. Perfect. Perfect. All right, so we're going to start with repairing the it looks like the L34, I think, is where we're going. So I put my guide wire in. Shot. Now, for those of you watching, you can ask questions. I'll answer them for you during surgery, if I know the answer. If it has something to do with the spine or the economics of spine, pain management, therapy, medications, usually I can answer it. I'll do my best. All right, so we're going to start at L34. This line here, by the way, represents the midline of the patient. That's the middle of the patient's back. Normally, every other surgeon makes their incision here. But with the Duke laser disc repair, we come from the side, and I go what's called transforaminal. So if you look at the tip of the dilator, that pencil-looking thing that I just introduced along the guide wire, the tip of that dilator is at the facet joint, F-A-C-E-T joint. That's in the back of the spine. And as I advance the tip, I'm going through the foramen. That's the foramen, neuroforamen, where the nerve root comes out. Now the nerve root comes out above where I'm operating. Shot. All right, so see the tip is sitting inside the foramen, the entrance to the foramen. And then I'm going to advance it till I hit the disc. Shot. Okay, and I can feel the herniation right now. All right. So I'm going to use a mallet. It's a surgical tool. Shot. AKA hammer. To actually just lay still. Remember, our patient is not under general endotracheal anesthesia. There's no tube down their throat, which is actually a good thing. Anytime you have general anesthesia, there's always a risk of airway complications. Shot. So whenever we can get away without doing general anesthesia, it's always safer for the patient. Just lay still, you're doing fine. You may need to help me stabilize her. Is she strapped on?
Yes, sir.
Good. Take. Shot. You're doing great. Just lay still. All right. Lay still, you're fine. So we're going to wait for a minute and not proceed until our anesthesiologist gets her a little bit more comfortable. Huh? Yes?
Yes, sir.
Proceed.
We have a question.
Sure.
One of our viewers is wondering, why does my back hurt worse now after my L45-5S1 fusion?
That's a great question. All right, give me a second and I'll answer it for you. All right, you all see this tube here? This tube is about the same as the tube we're going to operate through. So I just want to give you an idea of the size. The whole surgery is being done through this tube. Okay, a tube this diameter. I'm actually using this one to drive what's called the tubular dilator. It separates the tissues and allows the surgeon to do their surgery. Okay. So there's a great question, and you can see the tip of this tube is right in the foramen at the back of the disc, and I'm going to advance it through the disc. Shot. While you're doing this, you want to make sure that you don't advance the dilator into the abdomen or pelvis. So look at the tip of the dilator, right? See how it's moved forward a little bit there? I've just got to be really careful with that to make sure I don't push it all the way through past the disc into the pelvis, because it can cause an injury to some of the organs. So I make this surgery look easy, and I talk through it, and everyone's like, yeah, grab some popcorn. But the reality is that, patients can die during the surgery if it's not done properly. I've never had that happen. I don't expect it ever will happen, as long as you're careful and you adhere to the steps properly. But I'm just saying, I've had a good run for 14 years without a single complication. But then again, I'm an exceptional surgeon, and I don't say that as a pat on my own back, but as the truth. Not every surgeon is trained the same way. There's actually a hierarchy of training programs where it's kind of like anything. You have to be, the higher ranked you are coming out of medical school, the higher caliber residency you can go to. So not every spine surgeon is the same. They certainly don't all know how to do endoscopic surgery. All right, so to answer your question, somebody's had a fusion in their lower back at L4-5, L5-S1, I believe, 2 levels. Now, wait a second. You have to be careful. You never want to pull unsterile, which is past that drape. You never want to pull that onto your field. All right, so you always have to have enough cable that's sterile. That way you keep it sterile. So the issue here is we want to swing this stuff around. Okay? So the problem is we're caught here, right? It's going to pull this way. I don't want that. So you have to make sure when I put this on, no, I don't want that there. I want this here. You can hold this there, but really you should have had this go underneath that. So you have to make sure that happens properly. Okay, so why would you have more pain after a fusion? If the fusion was done, we're going to assume for 1 minute that your fusion was done properly. It was a successful fusion. All right, and the doctor did a good job, and he fused you properly at L4-5, L5-S1, which is probably a 50-50 chance that that's the case, okay? There's also a 50-50 chance that there's a problem with the way he fused you. But I'd say for right now, let's assume the surgeon did a good job. He did a good fusion. It's solid. There's no movement at L4-5, L5-S1 because they're fused together. Okay, and that he fused you in good alignment. That means that he kept the curve in your spine, lordotic curve. It's a curve backwards. You want a curve in your lower back, okay? It's very important. Without the curve, you'll have back pain. Why? Because it shifts your spine forward, and then you have to compensate for that shift forward above the fusion and below the fusion, so you're going to get pain in your SI joints, and you're going to get pain in your facet joints above and below the fusion, okay? And that's because your alignment is not good. And I'm going to tell you this, that about 75% of spine surgeons don't understand proper alignment of the spine. They don't fuse their patients in proper alignment. So I would say there's a very good chance that your pain is coming because your spine is not aligned properly. And alignment has to be done during the fusion. If the surgeon doesn't align the spine properly during the fusion and give you that beautiful curve backwards that God gave you when you were born at L4-5, L5-S1, that you're going to end up having back pain as a result of the improper alignment. So for me to make a diagnosis on you, I would need to see an X-ray or CAT scan of your spine where you're fused, or even an MRI would be okay. So MRI, X-ray, CAT scan, some type of an imaging procedure. But my number one thought is that you did not get fused in proper alignment. But let's pretend for a moment you did. Why would you be having pain after your fusion? If you have good alignment and the fusion took and there's no movement at L4-5, L5-S1. The second most common cause for back pain after a fusion would be your facet joints, F-A-C-E-T joints. And your facet joints above your fusion would be the cause of that pain. Or if you are fused above the sacrum, then it could be the L5-S1 facet joints. Okay? Point is, facet joints. That is probably the most common reason for back pain or neck pain after a spinal fusion. And most surgeons don't even know what facet joints really are. They don't understand how important they are in causing pain. And so you probably have facet joint pain if I had to put money on something. But I haven't seen your x-rays, so I can't really tell you for sure if it's an alignment problem or if it's a facet joint inflammation problem. Another cause of back pain after spinal fusion is the sacroiliac joint, otherwise known as the SI joint. Very common cause of back pain after spinal fusions at L4-5, L5-S1. Probably accounts for, I would say, 20%, 1 in 5 patients with back pain after a spinal fusion is the SI joint. Other sources include the piriformis muscles. My point to you is simple. Your pain is coming from something, but you need a diagnosis. And the only way to do that is to get pictures, imaging like MRI, X-ray, CAT scan, and an examination, physical examination by a competent surgeon like me. So I'm happy to do that for you. We actually do free MRI reviews, no charge to you. Just get an MRI and send it to us, upload it on our website, MRI@dukespine.com. We do a free review of your MRI to tell you what's wrong, but I also will need to do a video conference, so I'll need to look at you and examine you over the internet. All right? So I did the best I could without anything other than your voice telling me you have a fusion and you're having worse pain, but I still need pictures and I need a physical exam to properly diagnose you. Another cause, by the way, could be infection. I didn't mention that, but that's a very important cause. If your fusion was done recently and your pain is getting worse, you very well could have an infection. And that's a very important consideration, especially if you had your surgery done in a hospital. I don't do my fusions in the hospital anymore because of the infection risk is too high for patients. I don't want my patients getting an infection. So I do all my fusions now outpatient in our surgery center. And we don't have any infections. We've never had an infection from our surgery here. We've been doing surgeries here now for 6 years, including all of our spinal fusions. Even L4-5, L5-S1 fusion. Okay? So you have to get it done in a proper environment. Hospitals are high risk for fusions to get complications. You really want to be selective about where you go for your fusion.
We had another question.
All right, I'm going to take the question in just a minute. First, I want to tell our audience what we're doing. Everyone see the metal tube I'm working in? That's the metal tube I slid down. Okay? And the end of the metal tube is right here where the metal ends. And what that blue stuff is and white stuff, that's inside the disc herniation. I am inside the disc herniation. Specifically, I'm inside the annular tear. That's what this blue line is. So I'm doing a debridement, an annular tear debridement. And folks, Duke Spine Institute here in Florida is the only place in the world that does annular tear debridements. We're the first ones to do it. I published it in my papers that I wrote on this procedure that have been peer-reviewed, and they're in the National Library of Medicine, indexed in a journal called Surgical Neurology International. Why is that important? Why do I care? I care because other surgeons don't do this, because they don't do endoscopic surgery and they can't see the tear. You can only debride an annular tear by doing endoscopic surgery. And not just any endoscopic surgery, you have to do intradiscal transforaminal endoscopic surgery, which is what we're doing here. And only probably about 100 surgeons in the world know how to do this type of surgery. I mean the world. In the United States, there's probably only 5. Most of the surgeons that know how to do this kind of surgery are in China, Korea, mostly Korea. There may be a couple in India and maybe one in the UK. But this type of surgery is not something done by most spine surgeons because it is not taught to them during their training. because there's only a few of us that know how to do this surgery in the world. And we don't work at the universities. We work in private practice. So we're taking care of patients every day. We're not teaching the new surgeons how to do this because they're not coming to us to learn. Fact of the matter is that the companies that sell screws and rods, they don't want surgeons learning this technique because you don't need to put screws and rods in the patient's spine when they have this kind of surgery. As a matter of fact, that's why people come here from all over the world to have this Duke laser disc repair, because I don't put any screws and rods and we don't do a fusion. This is done naturally. It's a repair of the disc. It's much better than a fusion. There's no disadvantage of this surgery compared to a fusion. A fusion is open and painful and basically barbaric when you compare it to the elegant surgery that we're doing right now. But the companies that sell screws and rods to do fusions, they have control over all the training programs for spine surgery. And they are making sure that the new generations of spine surgeons are able to put screws and rods in. And of course, everyone should learn that, but the truth is that there in the United States, there's 500,000 fusions being done a year on spines, and probably 450,000 of those fusions, so about 90% of them, we could not do the fusion and fix the patient with this surgery instead. So why is this not being done more prevalent? Because those implant companies are blocking this surgery from becoming taught at the universities. They don't want spine surgeons learning how to do this surgery. So that's why we broadcast. We broadcast because they can't stop me from broadcasting. And the public needs to know the truth, that there's a better way to fix backs and necks than fusion. Now, do I do fusion? Absolutely. I do fusion surgeries because not everybody can have this surgery. So they need to have a fusion instead. And we offer fusions. I do fusions almost every single week. Today we have 4 of these surgeries being done. And we have no fusions being done. So that gives you an idea. Last week I think we did a fusion. Or the week before, I should say. We did a couple of fusions. So at Duke Spine Institute, we can do anything in the spine, whether it's a fusion, whether it's artificial discs, whether it's laser surgery, whether it's a microdiscectomy, laminectomy, you name it, we can do it. There are some spine surgeries that I don't do here because this is not the best environment for them. And those are very complex fractures of the spine. For example, thoracolumbar junction fractures, I don't do here. Standby laser. I'm going to go in with a little grabber and try to grab that piece of herniation out that you see. How's she doing? How's our patient doing? Good? All right. Those of you wondering what I'm using what's called a pituitary rongeur. It actually opens and closes, you see that? And it's really long, and so it's made just for endoscopic surgery. Here you go. But 90% of what I do, probably 95% of my work is done with the laser. That's what you're seeing, a blue cable with a little glass end. And that thing is taking energy from a big machine sitting in the operating room at the feet of the patient. It's a laser unit. And it creates an energy wave or burst that travels through this long fiber. It's about 6 feet long. And it goes from the machine to the end of the tip right here. My hand controls it. And the laser is the most important part of the surgery. Without the laser, I cannot do the surgery. You see the blue? That blue indicates the disc material that's stuck in the tear. You see the tear right there? If I don't debride this tear, this patient will still have back pain after surgery. So the magical component of the Duke laser disc repair is the annular debridement, which nobody else does. Other surgeons do discectomy, but they don't do an annular debridement. And that's why they can't cure back pain. All right, we'll take the other question.
One of our viewers is wondering, do you give your patients the option to go under general anesthesia for these surgeries?
Do I give my patients the option to go under general anesthesia for this type of surgery? The answer is not usually. The only reason I would do general anesthesia on a patient is if they're complicated airway and they need to be under general to secure their airway to make sure they don't suffocate during the surgery. Okay? So the answer is no. And the reason is, if somebody came to me and said, I absolutely have to have general to do this, I would do it. But the reality is I need their help in the beginning. And I need their help placing the needles. You see, the reason for that is you're going through the neuroforamen where the nerve root is. And if you touch the nerve root with the needle, you want to know. And the only way to know is that the patient will tell you. Now, of course, after doing 1,000 of these surgeries, an average of 2.5 discs per surgery, I got pretty good at feeling with the tip of the needle, so I probably won't do any nerve damage even if the patient was under general. But the purpose of the patient being awake is to tell me if I hit their nerve. They're going to say, ow, you're too close to the nerve. And they're going to tell me they have pain going down their leg or down their arm. Well, actually, we put them asleep for their neck if you have a cervical disc. So to answer your question, we can do it under general, but I don't usually recommend it. Do I give my patients an option in the clinic? Not usually. But if they came to me and said, I want to do it, but I have to do it under general, I would consider doing that for them. As long as we can do it safely, and as long as the patient understands that there is a higher risk of nerve damage from the procedure. Now, I've never had a case of permanent nerve damage during this procedure. I had one patient who their nerve was had an abnormal anatomy where it was branching very close to the hole that I worked through, and so it was stretched a little bit. But we've never had a nerve damage on any patients in all the years I've been doing this surgery. And part of that is because the patients are awake at the very beginning and they tell me if I'm too close to the nerve. See, that area that I went in, the neuroforamen, has a nerve coming out of it. And that's why most surgeons can't do this surgery, is because they would damage the nerve. But I know exactly where the nerve is, and I know how to get in there and not damage the nerve. But I want my patient awake during the surgery at the beginning to help guide me to the right place, if that makes sense. So, all right, here's another herniation fragment. Now, why would that be inside the disc? Because remember, we had to, it's right there at the mouth. We had to push the dilator into the disc. The way that I do endoscopic surgery is I do what's called the inside-out technique, which means I start on the inside of the disc and I work my way out through the tear. And that technique is a technique I learned from a guy named Dr. Young, Anthony Young. And Dr. Young is an American orthopedic surgeon who's retired now. But Dr. Young taught me many years ago the benefits of this particular technique of going in the inside of the disc and working my way out. Now, there are other surgeons that start on the outside of the disc, inside the neuroforamen, and they actually work their way down to the disc. But it's much more risky if you start in the neuroforamen because that's where the nerve root is. So Dr. Young's point was that if you start inside the disc and work your way out, that you can actually be safer with respect to the nerve root. So that's the technique that I adopted and incorporated into my procedure that I do, the Duke laser disc repair. But the other thing is you can actually work the annular tear from the inside out, which is much better than just taking the herniation out in the foramen. Almost done with this disc. You can see the epidural fat there. You can also see inflammatory tissue. That's where all the back pain's coming from. Remember, the inside of the disc has no blood supply. The outside does. So we're getting to where the outside is, and we've actually, with chronic inflammation, those blood vessels and little nerves start growing to the inside of the disc along the annular tear. This was shown by a Swedish neuroanatomist. He taught me many years ago about how disc herniations and annular tears can become very vascularized from inflammation. That's what gave me the idea that the annular tear needed to be debrided to get rid of all that inflammatory tissue, because it's the inflammatory tissue inside the annular tear that is the source of back pain or neck pain in the cervical spine. And that's the heart of my surgery, the premise of the annular debridement. And it works. Again, in 2020, nobody else does it because they don't know. They're taught to do fusions. They're taught to do artificial discs. They don't understand that there's just a small area of the disc that's causing all the symptoms. It can be repaired with a laser, endoscopically, like we're doing today. We're just about done with this annular tear. You have another question from the audience?
No others so far.
All right, so for those of you watching, we're broadcasting this surgery live over the internet through Facebook, Periscope, and Twitter. No, not Twitter, but Facebook, Periscope, and YouTube. And so people from around the world can watch the surgery. We've had upwards of 100,000 people watching these surgeries. And it's just hit or miss. But usually we get about 1,000 or more people watching and learning. So if you're in the audience right now and you have a question, feel free to ask me. The blue thing is the laser fiber. And I'm at the back of the disc right now. And I'm just removing the last bit of herniation, the blue stuff. Okay? And debriding the tear. This is all annular tear. Why are we doing this surgery? We're doing the surgery on a patient who has 2 herniated discs, bulging discs actually, in her back. And she's been having back pain for a while. She did not want to have a fusion. The fusion would have fixed the problem if I had done it as well. She wanted a minimally invasive surgery with a Band-Aid. Basically be able to get back to her life quickly and not be on pain medications, recovering for months after a fusion. Fusion surgeries can work if they're done right, but the recovery from a fusion is much longer than the recovery from this Duke laser disc repair procedure. This is all scar tissue here from chronic inflammation. It's from the annular tear being inflamed for so long. It creates thick scar tissue. And that's what the laser is really good at removing. There's really no other instrument that you can fit down this tube that would do this job. So the laser is essential to the surgery being done properly and effectively. How does the laser work? Well, it's basically like you see in Star Wars. It's a beam of energy that's delivered to tissue, and it just causes disruption of all the covalent bonds in the tissue. And then there's a pulse that comes with it that actually blasts this debris out of here once it's been released and freed up. So if you look carefully in the water column, you can actually see little bits of tissue floating away. What you guys see is the laser just zapping this tissue and it disappears. Obviously it goes into the water around the laser in this tube, and it's carried out to the surface of the body and then into a bag that we collect it all. Just about done with this disc. About 2 minutes left. Then we'll start on the next disc. This patient had 2 discs that are causing her pain, L34, L45. You want to make sure this 12 o'clock position that my fiber is at is the median, towards the middle of the patient, towards their nerve roots and their spine, okay? And you also want to make sure you clean up laterally as well. You can get into some weird anatomy laterally. There's a tear there. You want to be careful because there is a nerve root running right outside there. You don't want to hit it with your laser. That's all herniation. A lot of people ask me, when you're done, what happens to the tear that's there? Does it heal itself? The answer is yes. It heals itself. So we give all of our patients lifting restrictions for about 3 months after the surgery. They have restrictions while the disc itself heals, okay? So your body will heal this very nicely without any issues as long as you don't re-herniate your disc while you're healing. So the lifting restrictions are to prevent people from re-injuring their disc while it heals. Until this disc is healed, it's very delicate. It can be re-injured very easily. Especially the first few days, you know, until things start healing and getting sticky, we call it. Thank you. All right, I think that's about it. There's the epidural space. So the exiting nerve root, whoa, laser standby. Don't let it hit your mask, bring it away from your face. All right, the nerve root is right there in that fat. And I think it's looking good. Yep, the herniation's gone. I may get that little bit right there. Watch that loop. You have to understand, when you give me that end, the loop was going to move. So you have to keep it away from you. Some of you may say, why are you teaching the world? No, you got to move it away. You got take this, move this hand here away from your, stop. Take that, grab that. Let me have the fiber. Let go. Okay, stop. Let go. I'm handing it to you. Do you see this loop? It can hit your head. So no, use your right hand and push away from you. Grab it where you had it. Push away from you. Don't hold it close to your face. Push away and take this. All right. Scope off. Watch it. That's my job. Let go. Take this off. That's your job. All right. Light on. Let's get the fluoro in. Move out of the way, please. Move out of the way. You should never contaminate this. You need to watch it. Your shoulder almost touched it. Come in. Okay. I don't know what you're doing, but why don't you get a shot and figure out where you are, Jordan? That looks pretty good. Shot. How's she doing? Shot. I need the table up just a smidgen. 1/4 inch. That's good. Hold on. Shot. All right. So it's good. Our tip is in the foramen at the back of the disc herniation. Everything is going well, shot. Okay, we're at 4-5. We've already done 3-4. Yes, let me have that. Shot. Looking good. Shot. Good. Hold pressure here. Off, relax, relax. Take this. Shot. Shot. All right, very good. We've lost about maybe 2 milliliters of blood this whole surgery, because we're doing everything through a tiny little incision. Shot. You can see the tip of the dilator, or tip of the tubular retractor sliding along the dilator. It's right at the back of the disc. Shot. Once again, you have to be very careful not to advance the tip of your dilator into the pelvis. Okay, so I'm going to bring it back just a little bit. Let me have the tool. Watch that there. Shot. All right, take it back just a little bit more. Shot. Good. All right. Now I'm going to put the impactor back on and shot. Just finished putting our tube in. I'll need that tool. So the reason it sticks is there's a little bit of disc material. Shot, perfect. Okay. Get rid of this. Okay. All right. Watch your arm. Just move away a little bit.
Jordan, you can go. I mean, not go of the room, but like you can move this.
Huh?
Scope on.
Yeah. All right.
So at this point, Sam, help me more. Yeah, it's going.
All right.
At that point,
We're ready to do the next disc.
he always like it. And then that's
Put it in my hand properly. Yeah. All right, good. You see the blue dye? We put that in there. That's staining the herniation. That way I can find any herniated fragments. Take it. And now I'm going to bring my laser in. Because the metal tools that surgeons typically use, like pituitary rongeurs, they don't really work that well. Hey, watch your face. Is the laser on? Once again, this is that herniation right here. You see it? That's called the interposed herniation. Interposed. It's stuck between the torn annular edges. It's what's causing all the inflammation to happen. It's causing all the pain and in the back and down the leg. When it happens down the leg, is all due to this tear with this wedged in herniation. We call the wedged in herniation called the interposed herniation. Interposed. Because it's interposed between the two edges of the annular tear. You see the annulus is thick. It's usually about 8 millimeters to a centimeter thick. Okay? About 8 millimeters thick. It's got about the thickness of this tube I'm working through. This tube internal diameter is about 7 millimeters. So imagine side to side of the tube, that's how thick the annulus typically is. So when you have a tear in the annulus, you have a pretty thick tear. I mean, it's a tear through a thick annulus. And once again, the tear happens and then the jelly in the center of the disc squeezes out through that tear. Some of it goes all the way out, and that's the herniation that everybody talks about on MRIs. And some of it stays wedged into the tear, and that's the part that I fix with my surgery. And that's the part that actually causes the back pain or neck pain when you have a herniation. Most doctors don't know that. I'd say probably 99.9999999% of doctors don't know that fact. That's why patients with back pain and neck pain that go to their doctors, wherever they are, their doctor says there's nothing that can be done, we don't know what to do, go do physical therapy. They don't know how to fix this problem. That's why we're broadcasting, so you people that are suffering can find a place to get fixed. Because you're not going to get fixed where you are. They don't have this technology where you are unless you live here in Florida. Which is why we have people travel all around the world to come here. They travel from all around the world to come to Duke Spine Institute because we do this surgery here. And they can't get it done anywhere else. We have a lot of Canadians, we have a lot of Europeans. We're still getting the word out in other countries, and obviously getting the word out is really the biggest part of it because, you know, think about gunpowder, right? The Chinese developed gunpowder, and until that knowledge and information about gunpowder, how to make it, how it's used, until that was shared and distributed around the world, other people were still using, you know, swords to fight battles, whereas those people with gunpowder could make muskets and cannons, howitzers, and of course military supremacy, right? You put them on ships, you put it on forts, you can defend yourself. The point is that with gunpowder you had a major technological advance in warfare. You were then having muskets and cannons against people with swords and bows and arrows, okay? My point is this technology you're watching right now needs to disseminate. This is like gunpowder in the spine surgery world. The problem is 98% of spine surgeons don't know about it because they were never trained on it. They have no idea this procedure even exists. That's how bad it is. So it's really going to be up to patients to, they're the ones who are going to benefit from this technology. They're the ones who have to learn about it and utilize it to their advantage. If you're just sitting around waiting for your doctor to learn this technology, you're going to be waiting for a long time. That's sad to say, but it's true. Shouldn't be that way in medicine, I agree. You know, but the truth is that's how it is. Discoveries are made in small pockets of the world, small corners, and then eventually it takes years and years for that information to disseminate. So why are we broadcasting? Well, we want to disseminate that information so we can help more people sooner. They don't have to wait 20 years to find out about this endoscopic surgery. Yes. What is it? We're going to be done in 10 minutes. Probably 10 minutes or less. We'll have the bandage on. Okay? Yeah. Well, I'm mostly talking to our anesthesiologist so that he, I know, I heard you, so that he can, you know, adjust the anesthetic. Just about done. I'm working laterally here. So this tear wants to heal naturally. Your body is trying to heal the tear, and it can't because there's too much jelly stuck between the tear edges, the edges of the tear. So to help the body heal, that's what the Duke laser disc repair is. I actually go in and remove the jelly that's keeping the tear from healing. See, I'm giving you all my secrets. Secrets that I had to work very hard to learn, to discover. Why am I sharing it? Because I know that someday I'm not going to be here, and I don't want this information to die with me. I want it to become something that people benefit from all over the world throughout time into the future. This is a futuristic surgery you're watching. I heard the other day that they found the Holy Grail. Of course, it's probably fake news. I read it on Facebook, right? They said they found it in a church in Portugal where the Knights of the Templar hid it. So think about that technology. Imagine if there was a Holy Grail. I mean, for good or bad, we're not here to debate that. Ethically and morally, is it a good thing? But imagine if that technology existed, but it was hidden away. Nobody could benefit from it. Okay, I can't move this. You have to let me roll it. Imagine if, only a handful of people would benefit from that. Doesn't seem right. It should be available to the world. That's what I'm trying to do with the surgery, is make it available to the world. So not just for a few privileged people.
We have a question.
Yeah.
One of yours says, you said that a lot of surgeons don't know this procedure exists. How
Yes.
did you come to learn and perform this type of surgery?
That's a great question. So the way I learned the surgery was I learned the basics of the surgery from surgeons overseas. This surgery was most popular and most used overseas in a country called South Korea. All right, and the South Koreans learned the surgery from a doctor named Dr. Parvis Kambin. Parvis Kambin. Dr. Parvis Kambin was an American orthopedic surgeon back in the 70s. He discovered this technique of going through the hole that I went through to get to the disc, okay? And Dr. Kambin, unfortunately, had very little support. And so he wasn't a great engineer, in my opinion. And he had very rudimentary tools to do the surgery. So the tools he had to use really caused a lot of complications because they were too big, too bulky. He didn't have the nice stuff we have now, these sexy instruments from Germany, okay? So Dr. Kambin was the pioneer of this technique. He taught the South Koreans. The South Koreans perfected it, or didn't perfect it, they made it better. They taught me overseas when I traveled overseas to learn it. So I learned the basics of how to place the needle, how to put the tube, the dilator, all that stuff. The part about using the laser to debride the annulus, which is what I've been doing, that I discovered myself by doing these procedures and checking on my patients afterwards and seeing how they were doing. And whenever I did an annular debridement, I found the patient's back pain went away. When I started doing it in the neck on the cervical disc herniations, I found their neck pain went away. So it wasn't long before I realized that what I was doing was I was curing back pain and neck pain by cleaning up the annular tear. So I incorporated it into my procedure and then I published it. And that's why it's been published. Now look at that right there. That's a vein. We call it an epidural vein. Look how perfect it is. It's got a thin wall, lots of blood. We're going to leave it alone. All right, just to the north of it, there's the nerve root. You all see the nerve root, that white thing there? It's got a little bit of blood vessels on it. That's the nerve. That's the patient's left L4 nerve root. Okay, so the herniation's gone. Off laser, off scope. We're done. And I think her back pain will be gone forever as long as she, I need this thing first. As long as she doesn't re-injure her back. So we're going to put our patient in a back brace so she can't bend over and pick things up, and we're going to give her a lifting restriction of 25 pounds for 6 weeks. We do that for everybody, and as long as they follow those instructions, they're going to do fine. They're not going to have any problems. Their disc will heal, and the pain will be gone for the rest of their life. So that's how we cure back pain, folks. Now, just grab that for a second. I'm going to show our audience just real quick. Here, let me have that. Let me have that. All right, can you all see this? Can you turn the light back on?
Yes,
The
we
overhead
can.
light? All right, folks. Can you all see this tube? The entire surgery was done through this skinny little tube. This is about the diameter of a pencil. And we're able to do it because we have the right equipment, okay? And I've been trained on how to use it. I've been doing it now for since 2006. So that's 14 years. This long endoscopic rig goes down that tube, and that's how we do the surgery. Let me show you the incision. Both of those discs were fixed with, it's about 8 or 9 millimeters. I made it a little bigger, but normally a 7 millimeter incision. We lost 2 milliliters of blood, hold that, and our patient will be awake and home in an hour. Yep, so great surgery. I'm going to come answer questions. So go ahead and start typing up your questions. Again, I'm Dr. Ara Duke-Majin, CEO and founder of Duke Spine, and pioneer of the Duke Laser Disc Repair, which you just watched. Once again, this patient's only other way to get rid of this pain would have been to have a fusion, and we saved her from that. We have, I think, 3 more of these surgeries today, right? 2 more, and then a spinous process thing. All right. Sounds good. I'll be over there in a few minutes to answer questions, so start typing.
All right, thank you for joining us for the post-op Q&A. We have Dr. Duke in the room with us after surgery, ready to answer some of your questions. One of our first questions comes from a viewer on Facebook named Karen, who asks, how is the patient's pain going to be managed after DLDR?
Hi, Karen. Thanks for asking. This is Dr. Digmajan with you. And the fact of the matter is that with these Duke laser disc repair surgeries, patients only need Tylenol. Tylenol, over-the-counter Tylenol. There's no narcotics given. We do give a muscle relaxer because I didn't cut the muscle, but I went through the muscle. So the muscle does spread apart. It doesn't get damaged, but it gets irritated. And there's, obviously there was very minimal blood. But as you pass the instruments through the muscle, there can be a little bit of blood on the muscle, and that can irritate the muscle. So some people will get muscle spasms, most don't. I would say 75% of the patients just need Tylenol. The other 25 will need Tylenol plus a muscle relaxer for muscle spasms. And that's usually just for a couple of days. So no narcotics are used, no opioids. Everybody knows about this quote-unquote opioid crisis. It's been a crisis for a long time, folks. I don't know if you know that, but long story short, if you have open back surgery like a fusion, which would be the alternative surgery for this patient to have L34, L45 fused, she would be on opioid narcotic painkillers probably for at least 6 weeks to 2 months after surgery. But with the Duke laser disc repair, there's no need for any of those powerful painkillers, just Tylenol and a muscle relaxer. So it's wonderful in that sense as well. Thanks for asking the question.
Our next question comes from a viewer named Sophie on Facebook, who asks, what surgery treats radiculopathy?
Hello, Sophie, and thank you for asking your question. Radiculopathy and what surgery treats it? So for those of you who don't know what radiculopathy is, the spine itself, everyone thinks of the spine as having, bones in it and discs, but what does the spine actually do? It does several things. One of the things it does is it allows us to stand upright because all of our muscles and organs and intestines, everything is attached to the spine. So it acts, we call it the spinal column because it functions to basically hold us upright, like a column. Now, the spine also protects and houses what's called neural elements. Neural elements. What are neural elements? Well, we all have heard of the spinal cord, right? The spinal cord is a cable. It runs from your brain down to your tailbone almost, and it has nerves that come off of it. And those nerves are like little wires that connect really the brain to your muscles and your skin to make things move and to give you feeling. So the nerves that come out of the spine, they come out through holes on the side of the spine called neuroforamen. And we actually went through the neuroforamen today to get to the disc. But we had to do it carefully, and that's why the patient's awake in the beginning to help me make sure as I get in that neuroforamen to the disc, I don't damage a nerve. So I've never damaged a nerve in all my career, in 22 years as a neurosurgeon. And I don't want to start today. I don't want to start with anybody, and I don't want to start with this procedure in particular. It's a great procedure. It can be done safely without any nerve damage as long as you do the technique right and the patient's awake to help you and guide you. So these holes where the nerves come out, those nerves leave the spine and go down to your arms and legs, all right? So there's 5 nerves that come out of the spine on each side, left and right. So 5 on the left, 5 on the right. They go down your arm, and they go to all the muscles in your arm. They allow you to use your arms, basically. And they also go to the skin, and they innervate the skin so you can feel things with your hand, your arm. So there's another 5 nerves left and 5 nerves right in your lower back. They go down into your leg. They do the same thing. So you got 5 nerves that come off the spinal cord inside the spine and leave through the holes. These are 5 separate holes, one on top of each other, and they go down into your arm. And then there's 5 nerves that go down into your leg, 5 nerves per leg and 5 nerves per arm. Anyway, the part of the nerve that runs right behind the disc, right before it exits the spine through the neuroforamen, that part of the nerve is called the nerve root, okay? And the nerve roots leave the spine through those holes. The nerve roots are particularly susceptible to injury because of their location and because of their size. So the nerve root is a big fat bundle of axons and neural elements, and it runs right out that hole behind the disc. So when there's a problem with the disc, like a herniation where the disc bulges out backwards right towards the nerve root, that disc herniation can actually affect the nerve root. And when it affects the nerve root, it never affects it in a good way. It's always bad, okay? It's always bad. So when you get a herniated disc or a bulging disc right next to the nerve root, it can cause symptoms in the nerve root, and we call those symptoms radiculopathy, okay? Radiculopathy. Now, if the symptoms that the herniated disc pushing on the nerve root are caused by pushing on the nerve root, it's called a radiculopathy generally, because it's a dysfunction of the nerve root. It's a dysfunction of the nerve root. The nerve root isn't working properly. And it manifests itself clinically in the patient as pain down the leg, called sciatic pain, or neurogenic claudication, which is discomfort and pain in the calves and thighs with walking and standing. It gets better with sitting because sitting takes the pressure off the nerve. Just sitting forward actually opens the holes where the nerve come out and releases the pressure on the nerve. You can also have tingling, we talked about earlier, paresthesias. You can have weakness, you can have numbness of the skin. So any kind of dysfunction of the nerve root is considered a radiculopathy. Now, sometimes there isn't so much pressure on the nerve root by a mass, like a bulging disc, herniated disc, or even a bone spur for that matter, but there's actual irritation of the nerve root. So without actually putting pressure on the nerve root, your body is able to irritate it, okay? So it's kind of like children fighting, you know, they irritate the hell out of their parents, right? I know that because my kids, you know, create problems sometimes. They irritate me. They're actually not physically beating me up, but they're just irritating me, right? And so the nerve root itself can be irritated as well without actually physically being touched. So how do you irritate a nerve root? Well, the way the nerve root is irritated is chemically. It's chemically irritated. And the chemicals actually come from the tear in the back of the disc. And that's why I developed this technique. I pioneered the Duke laser disc repair to eliminate the chemicals that are irritating the nerve root. Now, when I see a patient in my clinic and they have pain down their leg or their arm from irritation, all right, they have pain down their leg or arm, 95% of the time it's from irritation of the nerve root. Irritation, not actually physically compressing the nerve root, but irritation. And this is why Duke Spine Institute is so successful at treating patients with back pain and neck pain or leg pain and arm pain, is because other surgeons are only looking for something crushing or pushing on the nerve root. They don't understand the chemical element that can actually irritate a nerve root and cause symptoms, and they ignore it like it doesn't even exist. We call that chemical irritation of the nerve root radiculitis. Radiculitis, itis, I-T-I-S is at the end because it's inflammation of the nerve root covering due to the tear in the back of the disc. Nobody really knew why the nerve root gets irritated, but there's two things that cause irritation in the nerve root. And I've discovered these two things, and I am the one who's announcing it. I'm going to publish it someday. But it is inflammation within the facet joint or inflammation within the disc, the posterior annular tear. Either inflammatory source can get on the nerve root and cause a radiculitis, okay? Now, if you have a lot of inflammation, you get adhesions. These are the scar tissue adhesions that you hear about sometimes. Doctors going in and taking a balloon and putting it in the spine and breaking up adhesions, all right? The RAX procedure is one of them, but these are not commonly performed anymore, and unfortunately, you know, a lot of doctors don't know about it, so it's not very popular, and patients end up suffering with radiculitis when they don't need to. Long story short, radiculitis, inflammation and irritation of the nerve root, radiculopathy, compression of the nerve root by a herniation or spinal stenosis, which is your bone spurs, your buckling ligaments, your disc bulges, your disc herniation, your disc osteophyte complex. All right, spinal stenosis, narrowing of the holes, causes radiculopathy. Chemical irritation of the nerve root causes radiculitis. Both cause leg symptoms, but the most common by far, in my experience, and this will be found to be true for everyone, is 95% of leg symptoms or arm symptoms are due to chemical irritation of the nerve root, due to the tear in the back of the disc causing inflammation, which leaks onto the nerve root and causes arm and leg symptoms. Okay? You heard it from Dr. Duke Majan at Duke Spine Institute, because I'm the one who discovered that. You won't hear it anywhere else, and that's why there's so many people suffering with symptoms, because the doctors don't understand that there's a chemical component to nerve symptoms, not just a structural physical component that causes crushing of the nerve. Most doctors are focused on the crushing component, which is rare. The most common, again, is the chemical component, and that comes from a tear, which is what the Duke laser disc repair fixes, or it comes from the facet joint inflammation, which gets better with a facet joint injection. We have another question. All right, so let me give it back to Sean, my assistant, and he'll pose the question.
Another one of our viewers, Bob on Facebook, asks, what % of patients who get DLDR done have 100% pain relief?
Hi, Bob. Thanks for asking that question. The question was, Dr. Duke Majan, what percentage of patients having the Duke laser disc repair get 100% pain relief? The answer, 50%. 50% of the patients having this procedure will have 100% pain relief. The average pain relief for all patients is 95%, which is pretty darn close to 100. So if you're one of 10 patients having the Duke laser disc repair, your average pain relief will be 95%. It's a great question. I can digress a little bit to explain why. Here's why. It's simple. The people that we do the Duke laser disc repair on all have pain from a herniated or bulging disc. Okay, and therefore, as long as the patient has pain in their back or neck coming from a herniated or bulging disc, and I choose, as your surgeon, I choose the proper, correct discs that are causing that pain, then I'll give you 100% pain relief every time. Guaranteed, basically, guaranteed. So here's where things get a little sticky. Situation number one. You come in and you have 3 bulging discs in your neck. I only operate on 2 instead of 3. Well, you're going to have pain coming from that 3rd disc that I didn't operate on, and you're still going to have that pain after surgery. So as long as the patient and I agree to operate on all the discs that are causing their pain, then they're going to get 100% pain relief, period. And that's what we see every single time. Now, why do patients get pain after surgery? Here's why. Let's say you come in and you have pain from your herniated disc. I repair it. The pain is now gone. I put you in a back brace. I put you in a back brace because I don't want you to re-injure the disc before it heals. It takes, honestly, a full year to completely heal the disc after surgery. So the first 3 months is particularly, you got to be particularly careful. You don't want to re-injure it. Now, what's the re-injury rate? 1%. 1% of every patient that I've done laser surgery on will re-injure their disc by doing something they're not supposed to do. And that something is usually bending over at the waist, picking something up from the ground like a basket or a bag or something, heavy. They pick it up because they're feeling good, and bam, they get a sudden pain. They re-herniate. So they get another herniation right where I just operated because the disc hasn't healed. The re-herniation rate, once again, is 1% in Duke laser disc repair. That's 1 in 100 patients will have that. They'll have to have another surgery. All right, so let's just say that you don't re-herniate. We got you in a back brace. You've had your laser surgery for your herniated disc. I've gotten rid of the disc pain. But because you're in that back brace for 6 weeks, and you're basically wearing it all the time when you're out of bed, that back brace may actually make you have some pain because of the back brace. It causes your muscles to ache and get tense, which is why we do physiotherapy. But let's say you don't do the physiotherapy. Let's say you ignore doing the physical therapy after surgery, so you ignore it, you just wear the back brace, and now you're starting to get tightness in your back, discomfort, burning, searing pain. Well, that burning, searing pain you're having is not coming from your disc that I fixed. It's actually coming from your muscles, because the muscles are getting sore and achy because you're living in a back brace and not doing therapy. So when people have pain after surgery, it's not coming from their disc, it comes from something else. And it could be the way they're walking. It causes bursitis or irritation of the SI joint. Fact of the matter is, about 25% of the patients after surgery, they end up getting some other source of pain that we end up having to treat. About 25% of patients. The most common is muscular, and it just needs therapy to fix the problem. So great question. I'm glad you asked it. The number is 50% of patients get 100% pain relief. That was our last question. We have 2 more of these surgeries coming up. I think they're 2-level, both of them, or just one of them? Both are 2-level. So all 3 Duke laser disc repair surgeries being done here in beautiful, sunny Melbourne, Florida, near Orlando, are 2-level Duke laser disc repair. They're all lumbar. We don't have any necks this week. We do get people who have herniated discs in their neck that want laser surgery. They don't want a fusion. They don't want an anterior cervical discectomy infusion. They don't want artificial disc put in. They want laser. And we'll be broadcasting those shortly. So stay tuned. This will be a good time to go pop some popcorn and refill your Diet Coke.